poster is Avanzando Juntas, Adapting an Evidence-Based Weight Loss Program for Hispanic Breast Cancer and Gynecological Cancer Survivors by AnaKaren Manriquez Prado, Staci Young, Sailaja Kamaraju, Patricia Sheean, and Kathleen Jensik, and Melinda Stolley.
Hi, everyone. Thank you so much for that introduction. As was mentioned, my name is Ana Manriquez. My project is called Avanzando Juntas, Adapting an Evidence-Based Weight Loss Program for Hispanic Breast Cancer and Gynecological Cancer Survivors. So not only is that a mouthful, but it is also, as I mentioned, it also pinpoints that this program or this project is an adaptation project. Provide a little bit of background. Moving Forward is a program that was started in Chicago with African-American breast cancer survivors, and it was a weight loss trial. Avanzando Juntas, the project I will be presenting today, is an adaptation of that original program, focusing, as I mentioned, with African-American breast cancer survivors. And what I'm going to present to you today is the adaptation phase of that program, of this project. So as I mentioned, our target population are Hispanic breast and gynecological cancer survivors. And this group is much more likely than their non-Hispanic white counterparts to have overweight and obesity. Now, this is something of concern because obesity increases risk for cancer recurrence, as well as other comorbidities such as diabetes, high blood pressure, etc. Now, as we all know, weight loss and weight management are hard. It's not only hard to lose weight, but it's also hard to keep off the weight. So as we were adapting this program, we really wanted to keep that at the forefront and create a program that was intentional and would allow our participants to achieve weight loss, but not short-term, in a sustainable way, and something that was long-term. So as we were adapting this program, we did so in two different phases. And in those phases, we met with Latina breast and gynecological cancer survivors from southeastern Wisconsin. Now, I do want to mention that throughout this entire process, including the implementation of the program itself, because we are currently piloting the program, we've engaged a community advisory board throughout. Now, this community advisory board has been comprised of community members themselves, so women who identify as Hispanic or Latina and who underwent cancer treatment, as well as representatives from organizations in southeastern Wisconsin, including 16th Street Community Health Centers, the United Community Center, After Breast Cancer Diagnosis, Aurora, Walker's Point, and more. So we've really tried to be intentional about bringing in folks who truly work on a day-to-day basis with our target population and know them, whether it's sometimes on a personal level, but also know their needs on a broader level and on a cultural level as well. So now going into the adaptation process in more detail, as I mentioned, we did this in two different time points. So we conducted a series of focus groups and interviews at time point 1 in order to really just identify what their needs were, what the needs of this population were, and anything with cultural significance that we wanted to make sure we incorporated in the adaptation of the materials and of the program itself. After that initial group of focus groups and interviews, we conducted those adaptations through a multifaceted content analysis led by Dr. Staci Young from MCW. After that initial adaptation process, we met with them again and we presented the things that we changed and the things that we adapted to the materials and the program itself to our participants, and we gained more feedback and more insight on things that they needed and things that they wanted to make sure we included in the program. So after that second time point of meeting with them, we then went back and continued to adapt the materials, continued to adapt the program curriculum, and really just refine the manuals to reflect what we had been hearing from our focus groups and our interviews. And as I mentioned, that coding process was led by Dr. Staci Young. After the interviews and the focus groups were transcribed, we went through and we were able to identify different themes and categories that were important to our participants. And I wish I had more time to go through in depth the different themes and the categories. But as you can see on this slide, the major themes were relationships and support, advocacy and empowerment, and wellness. Now, I am going to take a few more seconds to describe acculturation specifically, because what we found was that acculturation was cross-cutting in survivorship experience for our participants. So acculturation, very loosely defined, because it's really a very complex and multifaceted process, but loosely defined, it's changes in beliefs, values, identity, language that result from a subculture being introduced to a new culture. So typically, this will happen in immigrant groups or refugee groups after they are introduced to a new host culture or a host country. So in our program in Avanzando Juntas, we found that acculturation, as I mentioned, was really important because it was cross-cutting in their experience. So the participants' level of acculturation really dictated what their survivorship experience looked like. One of these examples is in our ability to recruit these participants to begin with. So as I mentioned, during the first time point of interviews and focus groups, we conducted both interviews and focus groups. However, we originally planned on just conducting focus groups, but because it was difficult to engage predominantly Spanish-speaking women in focus groups, we switched and pivoted to allow for interviews as well. At time point 2, once we had enacted some trust building practices, once we had truly tried to build a relationship with our participants, we found that the predominantly Spanish speaking ladies were much more comfortable with us and were willing to participate in focus groups. So as you can see, in time point 1, we conducted 12 one-on-one interviews, whereas in time point 2, there were only 3 predominantly Spanish speaking interviews. So the number went from 12 to 3. And we were able to have larger focus groups where we were able to engage all of our participants in a much more holistic way. So going back to acculturation and its importance in our project and in our adaptation process, we found that participants with lower acculturation tended to be more reliant on family, more likely to identify barriers over facilitators, and also relied more heavily on community advocacy as a source of empowerment. This was different from their more acculturated counterparts who were, as I mentioned, more acculturated to US host culture, and therefore they placed greater emphasis on physical appearance concerns, but they were also more likely to incorporate their self-research in patient-provider conversations. So that was one of the really big, findings that we collected from the focus groups and the interviews, and we've really tried to be intentional about incorporating that throughout our program, including now, as I mentioned, we are piloting Avanzando Juntas, and the participants are meeting twice a week at St. Augustine Prep, which is a school on the south side of Milwaukee. We have a control group who is following the intervention completely independently, and this group that meets twice a week. We are incorporating different accommodations for COVID-19, including providing virtual attendance options, and we've limited the class sizes to be much smaller as a result of COVID.
AnaKaren, I'm going to cut in right there. I'm so sorry. I want to make certain that you get time for questions. So we're at about time. If you want to do a quick wrap up, and hopefully we can take one.
No worries. Yeah, that was about it. Those are the COVID accommodations. And then I just wanted to say thanks to the other PIs for the study. And then any questions.
If anyone has any questions, please put them in the chat and I will relate them to AnaKaren.
Stop sharing my screen.
And I'm seeing no questions at the moment. So thank you so much. And thanks for the presentation and the submission. Really appreciate it. That was outstanding.
Thank you. Thank you, everyone.
Okay, everybody, we are going to look, and I do not see, we do not have Hannah back yet. So we're going to move on.
I am back.
Oh, you are back. Wonderful. I see,
Yep.
and you're on a different name here. This is perfect. So I'm going to reintroduce the first. No worries. That's great. I'm glad to have you back. So we're going to again introduce the impact of adaptive garden tools in central Wisconsin by Hannah Phelan and group. Hannah, take it away.
All right. Can you guys see my screen now?
We can. Thank you.
Perfect. Okay, so I'm Hannah Phelan. I'm recently newly married, so my name changed, so that's where the mix-up came there. But I'm a third-year student at the Central Wisconsin campus, and I'm presenting my project focused on adaptive garden tools in Central Wisconsin. So about 42 million people in the United States garden each year, and whether that's gardening at home or participating in a community garden, that's 1 in 3 households trying their hand at growing something. And what's even more interesting is that there's actually a bimodal distribution of ages that garden. So there's people 55 years and older who are like the consistent gardeners, but it's actually the millennials that are increasing our participation every year. So that's pretty exciting. But gardening is a great physical activity for people of all ages. It's been shown to reduce your pain, improve our mental health, and reduce the risk of chronic diseases such as obesity, diabetes, heart failure, all of that. However, when we're faced with physical limitations, such as like due to aging or disability, it can make it really stressful to, and even painful at times, to try and garden. So for my project, I wanted to create a set of adaptive garden tools that could be used by anyone to make gardening more accessible for their body. Whether that's not bending over as far to water the far corner of the garden, or standing up to weed and harvest. There's so many options to keep us healthy and make it so that we're able to garden for life. So my hypothesis was that if we improve access to garden tools designed for those with reduced or limited physical ability, then individuals who utilize the tools will be positively impacted by removing a barrier to activity. So for my project, I worked with my mentors and lots of different community members to set up programs where I would educate people about adaptive gardening. And we talked about different tools available, garden design, different types of like low maintenance plants that you could use, and then also the health benefits of gardening. And then I would demonstrate the tools that you can kind of see on the table there, and allow the audience members to come and try out the tools. We would usually do an activity like planting succulents or propagating herbs, something like that. And then after my presentation, I would explain my study and give the survey to anybody who wanted to participate. And these are the results that we got. So I ended up presenting to over 200 people within Marathon County. And of those people who did the survey, 95% said that the program had value to them. 85% said that they would be interested in utilizing adaptive garden tools because of the program. And then 85% also said that they would utilize a collection of adaptive garden tools if one were available to them. And these are just a couple examples of the different tools from the gardening set that we've got. So like in the upper left-hand corner, you can see the telescoping water wands. And then below that, there's an ergonomic watering can. In the middle, we've got hand tools with like a support arm cuff. There's these adaptive gloves that actually have Velcro, so that if you have like reduced mobility of your fingers or pain with sort of like gripping things and dexterity, the Velcro actually holds the tool in place for you. And then there's also the adapted like padded kneeler that can be flipped over and used as a gardening seat as well. So thanks to the generous funding from Incredible Bank and North Central Wisconsin Master Gardeners, I've actually been able to complete 2 full sets of adaptive garden tools. The plan is that one of these tool sets will be held at Marathon County Public Library and can actually be loaned out just like any other library resource. So books, videos, and now you can actually get garden tools as well. And then a second set will be at Mid-State Independent Living Choices in Stevens Point, which is this organization that specializes in adaptive technologies as well as advocacy and just helping people with disabilities make healthy life choices. And they're part of this amazing adaptive technology program called AT for All. And they basically will house the tools, make them available to anybody in the state of Wisconsin, and they actually bring the tools to the individual, teach them how to use it, and everything like that. So it's wonderful. Along with the tools at both of the locations, there'll be a booklet that has information about tools, where they can be ordered if you want to purchase one, creative ways that you can make tools from the items that you already have in your garden shed. And then also there's going to be a tool cleaning process so that we don't have any like disease spread between the gardens. So a special thanks to MCW Central Wisconsin. Dr. Norrbom and Dr. Amy Prunuske were both part of my project and really helpful. I worked with lots of community members, again, had wonderful funding sources, and the tools will be placed at the public library in Marathon County, as well as Mid-State Independent Living Choices. So thank you guys so much for listening. Does anybody have any questions?
Thank you, Hannah. Questions, folks, please put them into the chat box and I will make certain that they get to our presenter. While we're waiting, Hannah, I'll start with a question. What was the impetus for this movement and who did you reach out to initially to think about adaptive gardening tools?
Yeah, so the first person that I reached out to was Brianna Wright, and she used to work at UW Extension, Marathon County. And I was just brainstorming the ideas for my project, and basically like my training is in biomedical engineering before I got to medical school. And I was like, how can I combine my love of like physical medicine and rehab with engineering? I'm from a farming background, but I want to incorporate medicine into all of this. And we just kind of were bouncing ideas off each other. And then next thing you know, she was like, well, I've heard of other like counties and their UW extensions having adaptive garden tools for anybody that's in a nursing home or like wheelchair bound or any other sort of disability. And the rest is history.
Outstanding, thank you.
Mm-hmm.
Any other questions, folks? We've got one here from Carol Williams. Are we considering developing new designs for the tools based on feedback from the users?
That would be the ultimate goal. And that's kind of where I'm hoping that once I'm actually a physician and settled within a community that I can develop some sort of program like that. But with not knowing where I'll end up for residency, it's been really hard. I'm not even actually in Marathon County anymore for clinicals. So it's been difficult, but yes, that is the ultimate goal, is to kind of make this almost a design your own garden tool type of thing where I can partner with like engineering firms or fabricators to make exactly what an individual would need.
Excellent, thank you. Folks, we have time for one more quick question if anybody else has a question. All right, Hannah, thank you so much. We truly appreciate your presentation today and thank you for sharing with us.
Thanks, everybody.
Okay, what will we look at next? Let's take a look, folks, at a framework for transformed community academic partnerships to reduce cancer disparities, a case study. This will be presented to us by Tobi Cawthra, Master of Public Health from Medical College of Wisconsin Cancer Center, Laura Pinsino from Evaluation Plus, Beth Brunner from Wisconsin Cancer Collaborative, Deborah Thomas from the House of Grace Kingdom Ministry, Carol Williams from MCW Pharmacology and Toxicology, and Melinda Stolley from MCW Medicine.
Great, thanks.
Thank you. Take us away.
Okay. Trying to get that. Okay, thank you. I'm Tobi Cawthra, and I'm the program manager for the Community Cancer Science Network. I'm going to move on to slides that are readable. So just a little background. To meaningfully impact breast and lung cancer disparities, research and community must work together differently. The Community Cancer Science Network, or CCSN, offers a framework for transformed community and academic partnerships that builds on some recent applications of CBPR principles, which include equity and justice. Our framework contains 3 distinct phases: incubate, innovate, and integrate. I'm going to focus on the incubate phase as I talk about how CCSN supported our first funded project, the Cancer Disparities Curriculum for Research and Community Scholars through the incubation phase. We worked through establishing a trusted partnership and then a shared vision for solutions to address cancer disparities. The phase led, the incubation phase led us to co-design a curriculum for early career basic science researchers and community members to co-learn, share perspectives on health and research, and offer a new way for community and academic medicine to work together. The research scholar project team, who are the authors on the poster, met over approximately a 15-month period, weekly for 60 to 90 minutes, to co-create this project and then to develop a funding proposal. I'm the program manager, and I worked with Dr. Laura Pincinald, our developmental evaluator, to frame our agendas and our discussions and working through the next steps of our guiding principles, which you see on the left-hand side, and our strategies, which are on the right-hand side. Now, our strategies are probably actually less important than the principles, because it was our principles that really shaped the outcomes of our strategies. And when you look at this, you might think this looks familiar to a lot of projects, but I just want to call out a few things that were really different. Our community co-PI had equal power from the very beginning, from the conception of every aspect of this work through the funding proposal. We used our time together to build a relationship between all of the team members, which gave us the opportunity to begin to ask questions of ourselves and of others, and to challenge our biases and our perceptions. And we really worked through the idea that we didn't know everything, and we would consult experts, and we found out that we were wrong in some of our assumptions, and it resulted in us changing our methods and our strategies. We wanted to look for evidence after that time period of transformed partnerships. So we worked with a third-party evaluator to conduct journey mapping so that we could look at some 3 dimensions of these transformed partnerships. And we looked at a growth mindset, the relationships between our partners, and the interactions based on sharing power and decision-making. Our co-PIs reported that they came away with a strong, trusting, equitable relationship, and that this is a lasting connection, that they were part of something bigger and that they learned something new. But it also required a significant time commitment, and that while this was a worthwhile time commitment, there were at times where the process was confusing or frustrating. Despite all that, we came to a principles-grounded solution. And actually, this is where you see where our principles really shaped our outcomes. The curriculum resulted in a plan to bring together Milwaukee community members or community scholars and MCW early career basic science researchers or research scholars to participate in a shared curriculum over a 9-month period, where the research and community scholar will learn jointly from MCW faculty and experts in the community. It won't just be didactic learning, they will have experiential learning and project-based learning, where a research scholar and a community scholar work together in a dyad and then are able to disseminate to both community and academic audiences. And then to reinforce the learnings, the team is building an alumni network, which will continue that culture that is built within the curriculum and also extends who is influenced by the curriculum. So an adaptive framework and iterative processes provide the opportunity to quickly identify challenges and successes and to pivot strategies for successful outcomes. We saw that when individuals on our team experienced emotions which might lead them to give up the work, like confusion, or return to a more traditional approach, like frustration, our supportive structure and the transformed partnerships allowed the team to push beyond uncertainty. And I just wanted to thank all of our partners in this work, and especially the Advancing a Healthier Wisconsin Endowment, which provides the funding for both the CCSN Integration Hub and our curriculum.
Thank you so much, Tobi. We have time for a few questions. If anybody has a question for Tobi. While people are typing, Tobi, I'll start with one for you. Building relationships of trust takes time. And time isn't always simple during a grant project. You expressed that some of your users had frustration. Can you talk to me about how you built those relationships of trust in that short time period?
So it was a 15-month process that we took, and we were very fortunate that we had rolling deadline with our funder. So we were not tied to a firm deadline. So we were able to use the time that we needed to develop the relationships. In a short time period, I don't think we would have gotten to the closeness and the ability to really interrogate our own biases without that.
Excellent, thank you. Does anyone else have a question for Tobi? All right, Tobi, thank you so much for your presentation. We appreciate your time and for sharing with us. Okay, everybody, we're going to move to prescription medication disposal methods in Marathon County among the aging. Presented to us today by Shannon Phelan from MCW Central Wisconsin and Corina Norrbom from MCW Central Wisconsin.
Hi. I'm going to share my screen here.
Go to it. Take it away.
All right. Okay, can everybody see my screen?
We can, thank you.
Okay, perfect. So thanks for the introduction. My name is Shannon Phelan. I'm a third-year med student at MCW Central Wisconsin. And for my project, I partnered with the Marathon County Health Department, the AOD Partnership, and then also the ADRC of Central Wisconsin. So unfortunately, the opioid epidemic continues to be alive and well. Year after year, the community health needs assessment in Marathon County continues to identify substance abuse and particularly opioid abuse as a health priority. And there's been a lot of research on this topic, and research shows that as many as 80% of heroin users first misuse prescription medications. And we also know that expired and unwanted prescription medications, specifically opioids, are a pool of opioids that can be available for abuse. So we know that if we can reduce that pool of expired or unwanted prescription medications, that would lead to the prevention of future abuse and overdoses as well. During the Obama administration, the federal government recognized the opioid epidemic as an issue that needed to be tackled. And so they introduced the Prescription Drug Abuse Prevention Plan. And what this plan did is it mandated that drop boxes become available for community members to be able to bring their medications in order to be disposed of in a free way, in a way that is environmentally safe. So also to tackle this issue, there's also been drug deactivation systems that have been developed, one of which I have a picture on the slide here, which are deterra pouches. And how those work is you basically rip off the top and you can put your medications inside the pouch. You fill it with water, and then the water will activate, there's a charcoal pod on the inside of the pouch, and that will deactivate the drug ingredients inside the medications that you put in there. And those are single use, so you can toss them in the regular garbage, and then the drug ingredients are deactivated, and the bags are also made to be environmentally safe as well, so they won't fill up landfills essentially. Oops. So I always like to take the opportunity to briefly talk about correct and incorrect methods of prescription medication disposal. Some correct methods include permanent drop box locations, which I talked about. In Marathon County, there's 10 of them at the police departments, and then also the deterra pouches. And some incorrect methods are flushing down the toilet and the regular trash are two of the most popular. And unfortunately, these are incorrect as our waste disposal systems aren't engineered to handle these drug ingredients, and so the drug ingredients can be found leaching into our groundwaters essentially, so we want to avoid that. sorry. So essentially, the aging population in particular faces a unique set of challenges when it comes to drug disposal. Number one, they normally have more prescription medications, and number two, they may have a decreased ability to access police departments or the drop boxes in terms of their mobility. And so what we want to do is to evaluate the knowledge and current medication disposal practices among the aging, while also raising awareness of appropriate existing disposal methods like the drop boxes and the doTERRA pouches. And then we wanted to see is if Marathon County were to invest in these doTERRA pouches, if that would be a worthwhile allocation of funding in the future to reduce prescription medication abuse. So for methods, this survey, it was an anonymous survey that was distributed along with the doTERRA pouches. And like I mentioned before, we partnered with the Aging and Disability Resource Center of Central Wisconsin to be able to increase our reach and to really be able to give disposal methods to people who may have otherwise not had access. So the materials were delivered directly to the participants' homes, and when they were given 2 weeks and the materials were returned. Inclusion criteria, you must be a permanent resident of Marathon County receiving ADRC benefits, and there were 175 participants. So what we found in the survey is that 58.1% of participants took their medications to drop box locations as their main method of prescription medication disposal, which we like to see. This was followed in second place with 22.6% with throwing their medications in the trash, 12.9% flushing down the toilet, and other at 6.5%. Additionally, 37.1% of participants use their doTERRA pouch, and of note, participants that reported having expired or unused medications at home, of those participants, 100% of them reported that they did use the doTERRA pouch that they received. So conclusions, it can be concluded that we need to continue educating residents on safe and unsafe prescription medication disposal methods, considering that roughly 40% of participants said that they dispose of medications in ways that could be harmful to themselves, to others, or to the environment. And then also lack of doTERRA pouch use, which was 62.9%, can be attributed to participants who did not own any expired or unused medications. So I'd like to conclude by giving a special thanks to Melissa Moore of the Marathon County Health Department and AOD Partnership, as well as Dr. Norrbom and Rhonda James from the ADRC.
Thank you, Shannon. We have time for a couple questions. Does anyone have a question for Shannon? While we're waiting, I always like to ask questions, so I'll monopolize time. Shannon, did you speak to any of the people who didn't use the pouch, and what is it that your team thinks might be an inventive way or a creative way to go about getting increased compliance from the people who did receive pouches?
Sure. So we actually found that of everyone that didn't use the pouch, they actually didn't have any need to use it. Like they didn't have any medications that they were looking to dispose of. If that makes sense.
That makes great sense. Absolutely. Does anyone else have a question for Shannon? All right. Well, thank you so much for your presentation and for sharing with us today. We appreciate it.
Thank you.
Okay, everybody, we're going to move on to geriatric perceptions of weight and weight loss in a community clinic, presented by Elise Kahn from Medical College of Wisconsin and Leslie Ruffalo from Medical College of Wisconsin Family and Community Medicine.
Hi, can everybody hear me?
We can.
Okay, great. I'm gonna co-share.
Can we have you increase your volume just a bit?
Oh yeah. Is this better at all?
A bit better.
Okay.
Shannon, I think you're still sharing your screen. Can you end screen share with us, please?
It's saying the same thing to me too, that I have to quit in order to share my screen.
I see. Sally, I'm gonna ask you, have we come up with any solution for what that is?
No, unfortunately, we have not, but I just adjusted it so multiple participants should be able to share simultaneously. I don't know if that will help at all.
Okay, could we try one more time, please? Is this Elise?
Yeah, let me try one more time.
Oh, now I see you. That's great. All right, we're on the right track. Looks like it worked. Nice work, Sally.
Awesome.
Go to it.
Okay, thank you for that introduction. So my name is Elise. I worked under Dr. Leslie Ruffalo this summer in the Department of Family and Community Medicine. And our project was titled Geriatric Perceptions of Weight and Weight Loss. So a little bit of background on this project. I'm sure many of you know that both obesity and the number of people in the US over the age of 65 continue to rise. And also both of these things contribute to increased health services in our country, increased office visits, increased chronic diseases, and those put a financial strain on our healthcare system. Additionally, obesity has been linked to many of the leading causes of death in people over the age of 65, and those are shown in that graphic with the yellow stars. So our goal here was that in order to improve the care that patients receive in a clinical setting, it's very important for providers to understand the relationship that that these patients have in their perceptions between weight and how it affects their daily life. So our method, so this was a qualitative research-based study. The interview questions were conducted based on a literature review and also based on a project that was conducted last summer. And the questions were very open-ended with participants because we really wanted to key into that relationship. So an example of a question that we would ask is, as part of the aging process, has weight or weight changes been on your mind? And in the past few years, what factors have influenced your diet and weight the most? If they've changed, and if those have changed over the decades. So we really wanted to get them to tell their story to us. So our goal is to conduct 20 interviews, and our recruitment was done at the All Saints Family Medicine Residency Program. This was a little bit interrupted by COVID. I was supposed to be on site in clinic recruiting and conducting the interviews, but we had to change to a virtual platform. So we recruited based off of physician referrals, and they would give us their patient information that they thought would be good participants, and then I would reach out to them and conduct the interview. So far I've only conducted 4 interviews, but we were also able to use 4 transcripts from the project that was conducted the year prior. And so our data set is at 8 right now. So we analyzed the data using grounded theory, and they were coded for their main themes. So we only identified a main theme after the interview led to them. In other words, the data was completely driven by interview responses. And that really allowed us to take away any interviewee bias. And then this coding process was done by both myself and Dr. Ruffalo so that we were able to have a reliability system in place. So these are our preliminary results. So we found that the concepts that participants talked about were able to be split into 4 main themes. And those were the influence of age, patient context, and personal perceptions. Those included things like eating habits and motivating factors, and then also external context and social influences, which patients discussed a lot, and then also health influences, in particular, the connection between health and weight. And this was actually the thing that participants expanded the most on, and they keyed in on, most people talked about their weight in terms of their health and how it has been affected throughout their life. And so if you see at the bottom there, those are quotes from different interviews that I had. And so one quote that really stuck out to me was this one in the health influences category. So a participant said, I have a lot of back problems, and I know a lot of it is due to my weight, and I would feel better with my back and legs if I would lose some weight. I have high blood pressure and cholesterol, so losing weight would help with that too. So it was really salient in these participants' minds that there was a connection between health and weight in their life, and it has increased as they've aged. So some of our main takeaways were that, like I said, participants talked about their weight in the context of their health. Another really huge takeaway that we had was that participants talked a lot about the social influences that weight has in their life. And in particular, patients talked about food as a way to socialize. So I think in maybe a younger demographic, you might think of social influences as like social media influences and then perceptions of body image. And we didn't see that so much with this population, but we really saw social influences being impacted because people were unable to do certain things because of their weight, or if food was present, then they might not go to a certain activity. So that was a big thing that people talked about. The other one was that health literacy and comfort using technology played a huge role in participants' ability to manage their weight. And so that could create some disparities based off of health literacy and also access to technology. So that was something important that we noted. Participants also expressed an interest in learning about how the physiology of aging affects their weight. And that was something that we found in the literature review, is that there are a lot of changes that your body goes through and a lot of people are unaware of them. And so people express an interest in learning about these things, and in the hopes that if their physician can discuss them with them, then they can better manage their weight on their own. And so that is definitely something that we would relay to providers in the future. So our future work, we want to widen our participant pool to also include providers caring for elderly patients. And we want to do this because the relationship between patient and provider is really central. And in order to gather an understanding, we need both sides of the picture. So we want to talk to the providers and see what their perceptions are in addition to the patients. And then also what we're working on right now is a cohort of students that did research in the family medicine department. We're working on writing a manuscript that details the virtual recruitment process during COVID-19, because there was a large set of us that ran into some issues for that. And then also just a plug, we are still looking for participants. So if anyone out there has any referrals, I would be very happy to talk with you and then reach out to them. So I just wanted to thank Dr. Ruffalo for mentorship, and also this project was funded by the National Institute of Aging. And then those are our references. Yeah.
Thank you much, Elise. Does anybody have any questions for Elise today? Well, I'll always start with one if we've got a silence. So, Elise, given that there are several understood social barriers, economic barriers, and other to making healthy choices around nutrition, what were some of your personal takeaways when you looked at this population when it came to making choices, given all the social pressures that there are to maybe engage in an unhealthy diet?
So something that came up a lot was that people's choices were influenced by how they had lived their lives prior. And since they were in some of their older years, there was a lot of time for those things to build up. So there was just a lot of conflicting information that people had gotten. So I think that one way to kind of avoid that is for physicians to engage in conversations. It takes time in an office and so many things to do, but I think a lot of it comes down to their historical influences and then what physicians are able to talk about with them.
Excellent, thank you. Thank you so much. We're at time, so appreciate you sharing with us, and thanks for informing us about this project. Okay, next we have healthcare system support for caregivers of elderly adults through the lens of the medical community, presented by Annie Tuman from MCW and Leslie Ruffalo from MCW Family and Community Medicine.
Hi.
Hi, how are you?
Good, how are you?
Good, doing well.
All right, let me just share this here.
We can see it, take it away.
Okay. Start here. Okay. So hi everyone, thank you for the introduction. My name is Annie. I am a second-year medical student over at MCW, and this summer I worked with Dr. Ruffalo to learn how caregivers of elderly adults are currently supported in our very fragmented multi-specialty healthcare system. So kind of a little background on how I got introduced to this project. Dr. Ruffalo is part of a long-standing community academic partnership with ARIS Senior Network, the ADRC of Waukesha County, and Froedtert Health. And currently they're working on a grant to improve
support for unpaid family caregivers of elderly adults. And this is a really important area of research right now because many caregivers, especially those who try to help navigate complex medical needs across multiple specialties for elderly adults, those caregivers often report significant psychosocial stress and often report that they are not receiving enough support. So that partnership kind of led me into my research question, especially as a future medical professional. My goal was to explore through the lens of the medical community, what do medical professionals perceive support for caregivers to look like in our healthcare system, and who do they think is responsible on a clinical care team to make sure that the caregiver is considered in a patient's care. So to do this, we invited a sample of medical professionals across multiple specialties to interview with these semi-structured virtual interviews, and they completed a brief demographic survey. And the interviews were transcribed and analyzed in a qualitative analysis program called Deduce, where we used grounded theory and open coding to identify codes and themes related to how caregivers are supported in our healthcare system. In total, we had 12 participants, most notably breakdown by specialty. Half of the participants were primary care providers, 25% geriatricians, and 25% were specialists who regularly interact with elderly adult patients. So turning toward the central graphic, we identified 4 major themes that contribute to caregiver support in our healthcare system. The first in orange being the caregiver-patient dynamic. So this is relating to who the caregiver actually is, what their personality and stress levels are like, and what their relationship is like to the elderly adult. And then in blue, the caregiver-provider dynamic addresses things like how the caregiver is identified in a patient visit, how caregivers are engaged in that patient's care, and how the provider perceives their own role in supporting that caregiver. Next in purple is the multi-specialty dynamics. So that's referring to within one specialty, how is caregiver support shared between, for example, a physician, a social worker, and a nurse, or how is it shared between multiple different specialties? And then lastly, in red, there's the healthcare gaps and changes. So that's looking more at a systems-based level. What are some limitations and opportunities for improvement for caregiver support? And of course, how has COVID-19 impacted a provider's ability to interact with patients and caregivers? With only 5 minutes, I can only really highlight a couple major things, but one I wanted to point out in the top right corner is the caregiver support strategies seem to differ by specialty. So those providers who had a more specialized settings were more likely to say that they support caregivers in the form of education and synthesis, while providers who have more longitudinal, long-term relationships with caregivers and patients expressed that they try to be empathetic and listen to and ask about well-being for caregivers during the visits. And all 12, regardless of specialty, identified resource connection as being a critical role that they have in supporting caregivers. So a couple other big picture takeaways from our research so far. Caregiver support was not understood to be equitably shared amongst medical professionals. It was widely understood to be a primary care or social worker responsibility. And there were many limitations for support. Some of those included time constraints, inter and intra-specialty communication, billing, insurance coverage limitations, and professional boundaries. For example, some providers would talk about how a caregiver is not exactly their patient, so there's like a limitation there. For the next steps, actually this year I've already begun conducting interviews with caregivers, and I am looking forward to seeing if there's any differences between how they perceive caregiver support in the healthcare system with how the medical professionals have already identified. So thank you all for listening, and I'm happy to take any questions.
Okay, everybody, do we have any questions for Annie today? Well, as always, Annie, I'm happy to ask one. You identified some really interesting spaces, specifically in the interactions between providers around care provision. Do you see, based on your research and based on your findings, any way to untangle and better coordinate care and communication between providers to cut down on these, this tendency towards isolation or misinformation or conflicting information?
Oh, that's a
Sorry,
good
that's a tough one.
Yeah, I mean, that is definitely like one of the major questions I have. And in this research project, as I started, I think the more I analyzed, the more I realized how tangled it is, how based on your specialty, based on your training, based on who else is on your care team, there's just not much continuity between all these different specialties. So how that support looks is going to look differently. So I think just continuing the research and understanding also from the caregiver's perspective, I'm very excited to see if we can get a little bit more clarity if moving forward, what providers really can do to try to support them better in all specialties.
Excellent. Thank you so much. Thank you for sharing with us, and thank you for sharing your project.
Thank you.
All right, next we have Brain is Time by Abdulghani Munir and Timothy Guthrie, both from MCW Green Bay.
Hello, thank you for having us.
Absolutely, thank you.
Bodhi's going to share his screen here in just a sec.
We can see it. Take it away.
Awesome. I'll start off. So my name's Tim Guthrie, and my partner is Abudi. We're both third-year medical students from the Medical College of Wisconsin at the Green Bay campus. And we decided to do our Pathways project really on strokes. We decided to do a presentation on stroke awareness, stroke prevention, and really what to do if we see a community member presenting with a stroke. So to kind of go off a little bit of introduction, some basic information about strokes. Fifth leading cause of death in America, and up to 80% are preventable. They really come in two baskets. It's hemorrhagic or ischemic, ischemic being the majority of them at 80%. And they result from obviously a lack of blood flow, and then in a resultant lack of oxygen to brain cells, which quickly die. And depending on the location of the infarct, can present with a multitude of symptoms: paralysis, loss of muscle movement, difficulty talking, or memory loss. So kind of with this in mind, we thought it was essential for the community to be aware of this disease and understand both the symptoms that present with stroke and the predisposing factors that puts an individual at greater risk. So kind of moving forward, our purpose, our goal for this project was to educate the Brown County population, or the greater Green Bay area, on basic stroke prevention and detection so that strokes can be caught early on. So how we did that is we conducted a presentation on signs, symptoms, and risk factors for stroke in hopes that we can help people learn how to identify and prevent stroke. And we'll kind of talk about the method and how we did that here on this next slide. So our methods, we worked with the Aging and Disability Resource Center, the ADRC. I think another group was mentioning them earlier. They're a local community center that works with elderly and those with disabilities, and they kind of took us under their wing throughout this project. We set up 2 individual presentation dates that were advertised to the local community, and we had, I think, roughly 30 to 35 members come and sit through our presentations, which consisted of, I think, about 40 minutes of presentation, and then 20 minutes of kind of question and answer, and a lot of them shared experiences they had with stroke. So I think it was a valuable experience for both us and the community members that came. As far as statistical analysis, we did pre and post presentation surveys to assess the understanding of the content and check for statistically significant improvement in scores. And obviously the pre and post surveys didn't have any personal identifiers, and we labeled them with matching numbers to pre and post to see if there was a statistical increase in knowledge.
Yeah, so like Tim was saying, we use these pre and post tests to really kind of judge the understanding of the population study that we were kind of looking at, throughout our seminar. And we combined our data from 2 different seminars. We combined all the individuals that came from each one, and then we compiled this data. And we are looking here at question by question, what was the improvement seen pre-seminar to post-seminar. And I think you see the data all shows here, everything is statistically significant. Each question is a marked improvement, from the pre and post tests, which was great for us to see because we were teaching them something and we were able to interact very well throughout the whole presentation at the same time. They had a lot of great questions that we were able to help them answer. And I think it was really nice to see this data, when we put it all together. Here is just we're just taking a look at the overall performance, pre and post seminar. And this was just a really good understanding, a really good way for us to see, yes, they did pick something up over the course of the 2 seminars. So it was really great to be able to see that and to be able to work with this patient population. Yeah, in conclusion, we saw statistically significant difference between the pre and the post seminar. And I think above everything else, ignoring all of the data, ignoring, the statistical analysis, I think what Tim and I were really able to gain was a true appreciation of being able to work with the community. We were able to sit down with individuals that had no idea who we were, didn't really even know that we had a medical school campus in the area. And we were able to show them, A, how much we knew, and then B, they were able to ask us questions that they may have never been able to ask anybody else before, that they would have had to instead look at Google or talk about amongst friends. So it was really nice to get that experience and to really feel like we made an impact. And I think this was one of our most fun activities, I think, that we did during our first 2 years of medical school. We thought it was a great way to reach out and, share our knowledge and be able to help out as much as we could. Thank you. We cannot hear you. You're muted.
There it is. I knew it would happen sooner or later. Thank you so much for presenting. Does anybody have any questions for either of our presenters today? I've got one right away from Carol Williams. Nice study. I assume you did the pre and post survey both immediately before and after the seminar. Any plans to do a survey while after the seminar to assess retention?
We did do the survey immediately before and immediately after. We did not have immediate plans to do another seminar to assess for continuing knowledge. But what we did do was we talked to a lot of the M1s and M2s at our campus and asked if anybody would be interested in carrying on this project, either adding a different spin to it or just continuing it overall and trying to see the more numbers they could get, the better. Because a lot of the comments that we found after was, I wish I would have told more of my friends about this. And by that way, you can get more and more people involved, get a bigger population, and suddenly it becomes a bigger thing each and every year.
Excellent. I have one more question since I don't see any more in the chat. Since we know that language barrier in healthcare provision can be a really difficult barrier to get past, are there any plans or are there any ideas about expanding this into multiple language formats?
Yeah, I think that's a great idea. To be completely honest, part of the reason why we kept it just to English was it was a big IRB thing that we had discussed with one of our research advisors, and we didn't really have a good plan set in order to be able to include, different languages in this format. That is definitely something, though, that would be worth doing because we do have a few students who are very interested in like Spanish speaking, and being able to expand that into different communities in the area, I think would be a really great idea. So.
Outstanding. Thank you both for your presentation and for sharing with us today. We appreciate it.
Thank you very much.
Okay, last but not least, we have assessing efficacy of pre-hospital providers in correctly identifying CVA in De Pere and Ashwaubenon, Wisconsin, a retrospective study brought to us by Jamie Nelson and Patrick Best from MCW Green Bay.
All right, we are just going to share the screen here.
Sounds good. Thank you. How are we doing, Jamie and Patrick? Looks as though our presenters may have dropped and are trying to come back. So let's give them 1 minute, please. Thanks everybody for your patience. And this is just a great note in the moment here that we have that Dr. Med's also going to be addressing the group afterwards. So if you want to stick around in the main room, Dr. Saeed Ahmed will be addressing us one more time. So don't rush off immediately after the presentations if you've got a bit of free time.
All right, can you guys hear us now?
We can, yes, absolutely.
All right, sorry about that.
No worries.
We had the same problem that the first presenter and a couple ago did.
All right, we've got you up now. Take it away.
Good deal.
All right, so you already introduced us. Happy to be here. Thanks so much for having us. So this is our actual poster, if we were able to present it in a normal context. We broke it up into individual slides, as looks like others have done, just to make it a little bit easier to see. But this is our poster. So introduction. So CVA simply means that from some mechanism, the brain is no longer getting the right amount of blood flow. It's a silent killer. It places a really large burden financially, as well as in labor on our healthcare system in the country. There's two main types of stroke, ischemic and hemorrhagic. Ischemic means that there's an embolus that occludes a portion of the vessel that doesn't allow blood flow to move distally. And hemorrhagic means there's a rupture of a vessel in which there's bleeding into the cerebral tissue, lessening blood delivery to distal sites as well. CVAs often cause sensory and motor defects, as well as altered mental status and occasionally also death. So it's really important to have earlier treatment, solid handoffs between providers, and history. These are all known factors to be important determinants of outcomes, positive or negative, in patients with CVA. However, there's still significant question as to how efficiently we're identifying CVAs in the community as they're happening. Multiple stroke scales have been developed in order for rapid identification of CVAs in the field. And the LAMS, or Los Angeles Motor Scale, is one such example of a stroke scale in the pre-hospital setting that is used across the country, but importantly, it's used locally, and that's what we're seeking to investigate.
So essentially we wanted to find out, like in our local communities, particularly De Pere and Ashwaubenon, were these two pre-hospital EMS agencies using the LAMS scale appropriately to identify strokes? And we figured we would come to one of two conclusions. Either A, that LAMS is being used appropriately by these agencies to identify CVAs, or that it's not working the way they're using it. So either we need to adjust training to improve outcomes that way, or propose a different alternative, like a different stroke scale that they could use in its place. So this study was performed in a few distinct steps. The first one, importantly, was we needed to get records from De Pere, Ashwaubenon, and the local stroke center, Aurora Baycare, in order to kind of compare those two records, right? So we wanted to see in patients where CVA was the primary suspicion or diagnosis, and these patients were transported by one of these two agencies to this particular hospital, Aurora Baycare Medical Center, how many of those were confirmed to actually be having a stroke by either CT or by MRI? So if that had to be the primary impression of the EMS crew and the diagnosis for the patient leaving the hospital. So we didn't end up including anybody else in our patient pool because we didn't have records agreement with other people, and that we wanted to keep our patient population pretty small. So this is just a quick visual representation to show that on the whole, the two communities that we ended up getting positive records for and have them meeting all of our criteria, Ashwaubenon and De Pere were not noticeably different from each other, just by the false negative rate, true positive rate, those kind of things.
So looking kind of more holistically at our data, this is a table that represents some of our primary findings. So looking at sensitivity, specificity, positive predictive value, and negative predictive value. So sensitivity at 80%, meaning that of the strokes that are existing in the community, a positive test is capturing 80% of the tests. And specificity, meaning of those that our test deems to be positive, 50% are actually CVAs. And positive value means that of the tests that are positive, what's the likelihood that they are actually having a CVA? And negative predictive value is of the tests that are negative, what's the likelihood that what's the certainty that they are not having a CVA? So 80% sensitivity means we're catching a fair amount of them. 84%, well, I guess we'll talk more about that in the future. I'll just wait to cover that. So important conclusions. It's important to note that the LAMS tool was originally designed for more precise role of detecting large vessel occlusion, ischemic strokes. So that's one subset of the more broad stroke that we have defined as our project. So it's important to note that we have expanded the scope of our interpretation to include all instances of cerebral hypoperfusion, meaning ischemic or hemorrhagic events, to be in line with the clinical judgment of EMS professionals, because they're not able to distinguish them clearly in the field without imaging. And this is a major aspect of our inclusion criteria. Yeah, okay, I already said.
Okay, so it was interesting to note that sensitivities for the LAMS data between the communities that we were studying and the national data lined up pretty well. 80% for our communities, 81% nationally. We did have a low specificity value of 50%, which was below the national average, but there were only 6 data points that went into that formula as negatives. So that, just kind of like small sample bias, essentially. We discovered that the PPV of the LAMS was considerably higher than the NPV, essentially stating that a positive test means more than a negative test. And that's important to keep in mind when interpreting like our data in particular. So that kind of wraps up, a lot of what we wanted to talk about. We had, a lot of really helpful community partners to help us with de-identifying data, connecting records from multiple health agencies. And then, one of our community partners also helped us with the stats a little bit. So we had a lot of good help there. At this point, we'll open it up to questions from you guys.
Thanks so much.
I'm actually sorry, gentlemen. I really appreciate the presentation, but we are going to be pulled out any second now back into the main room. So I don't think we've got time for questions. We're going to get sucked out of this room. So thank you so much for sharing with us today. We really appreciate it. And I hope everybody sticks around because Dr. Ahmed will be speaking in just a few minutes in the main room.
Sounds good. Thank you.